Harish. Pleasure to have you out here.
By AI firms based in Canada and United States, which were able to predict the spread of COVID-19 even before the Chinese authorities or WHO had made a public announcement that there's something happening in Wuhan, which we have already seen that. So I think that's a real sign of what technology can help mankind in the future for early detection of emerging, let's say, a viral outbreak, and hopefully isolating it and preventing it from becoming a pandemic. So I think we are in for a bright future. Last point in impact of technologies, Raghav, would you have believed it when if I told you in January 2020 when COVID actually was a headache, that we would really see a COVID vaccine by November, December 2020? Nobody would have believed it. People would have laughed at us. But mankind has actually broken the world speed record for innovation in vaccine production. And this is absolutely to do with machine learning, to do with AI ability and quantum computing. This is what we have seen, right from decoding the architecture of and the genome of COVID-19 to really creating an effective vaccine in such a short span of time has never seen in mankind's history before. So I think we are all much better equipped to address calamities of this nature, and that way I think technology has really brought in good things for all of us.
That's great to hear. I think a very, very insightful perspective. And also, I think to probably a more pointed question on technology is, so that would mean that hospitals are going to spend much more on technology investments than what they were doing earlier. And if that's one. And secondly, I think how ready are the patients, and patients is, I would say, how ready are the stakeholders. So stakeholders largely, I think one is the patients, and the second one is the doctors. How ready are they to embrace technology? Or do they not? Or is it in a case that they do not have a choice?
So let me answer the last question first. So when you look at, that's why history is sometimes very amusing to when you look at it. Sometimes you scratch your head that, oh my God, did this really happen? Like in the early days of banking in India, if you reflect back, a lot of trade union, the first part of your question was regarding budgeting, capital budgeting, regarding IT projects. So there are multiple models available. You can go for a pure CapEx model or an OpEx model. Subscription-based models are available. And in these markets, which we discussed earlier, Egypt, India, or in the Philippines, the tech sector is quite vibrant. And because of competition and availability of programmers, the real cost of good HIs is actually coming down year on year. So hospitals really have plenty of choice based on their type of model. They can really lower their cost, expenditure, and cash outlay. But the fact of the matter is that you can really empirically make out an ROI for this investment, because if those hospitals which have a robust IT system, you can be assured of much better compliance towards loyal clientele, because the reasons are very simple. You have a high degree of operational efficiency, your throughput is far better, the ability for that hospital to consistently deliver service excellence and clinical outcomes are higher because it's in a structured, data-driven kind of an environment, and it's quite easy. And there are good tangible case studies out there that hospitals who have really invested in scalable and flexible IT platforms have really been future-proofed. And like the pandemic was a clear lesson that many parts of the world, they were actually playing catch up in terms of investment in the IT platform, because they had not done that before. So that's what, instead of playing catch up or firefighting, better to be wise and plan ahead.
Absolutely. I think I can relate to a recent conversation I was part of with Bill Ross of Mayo Clinic, who's the CIO of Mayo. Basically, he said they put together a 10-year plan for their IT roadmap, for a 10-year IT roadmap, and what was planned to have been achieved by 2030 has actually been achieved in 2021.
Yeah.
So
That's right.
I think it's a decade of progress in 1 year. So coming to hospital planning and implementation, all of us know that hospitals are capital intensive and are long gestation projects. A typical 200 to 300 bed hospital takes up to 3 years. 3 years, or it could, and if not managed well, it could run into 5 years. And we saw that some, very experienced people are making mistakes. So, what do what kind of an advice do you have for potential entrepreneurs or hospital investors into hospitals on how they can execute hospitals effectively? What factors are probably the most important? I'm not just talking about probably. I think we also talk about not just the hard part of hospitals, because a hospital means it also needs to have the software aspect. There is a manpower, the systems, and the operational processes. So all that put together, having a successful operational hospital. What do you think, in your view, would be very important to consider, and how can we efficiently manage them?
So that's a pretty good question with multiple parts in it. So if you look at the model of a project per se, based on the market conditions, you will have to decide whether you want to go on a greenfield route or a brownfield route. That's the first question. And even greenfield, there is one more model of going on an asset-light approach where the land and the facility is not owned by you, but by a third party. So that's another asset-light approach which you could do. But obviously, you as a provider, you would have a certain vision on the type of hospital you want. And therefore, the element of clinical planning and the space planning is fundamental based on your overall strategy on why do you want to have a hospital in the first place. So I think the most fundamental thing which investors or anyone thinking of a hospital needs to do, it has to be based on empirical research. And the empirical research has to look at the external environment, mainly to do with epidemiology, disease patterns, the existing competition in the market. So you get an idea of demand supply gap. Where exactly are your patients going to come from? The kind of the geographies. Is it based on certain kilometer distance, or is it much beyond that geographical area? So you need to get the source of your patients quite well. And of course, there are critical elements also, manpower availability, because sometimes you might have the capital and there is a market, but availability of healthcare workers is a critical concern, because many hospitals, in spite of able to construct the building, but you struggle to attract and retain good manpower. So that is also a pretty key part of successfully commissioning a hospital. Once you address these factors on how and why of the market conditions, then you set about having a core group which must involve a lot of consultants also based on your specialty mix, because getting inputs from doctors and the management teams are essential. Now, in my experience, it's always better that the CEO of the business or the P&L, whoever is supposed to run the hospital, is there from day one and should be part of the planning process, because many investors probably say that that's too early to bring in a CEO. But I would say that the CEO, if he's empowered to lead the business, should be there from that stage itself, because he can really influence the efficient operational aspect of that hospital. Usually, I've seen in some markets a long list of almost 35 to 40 different regulatory authorities who have to go through the process. So that the timing required for this regulatory framework should also be built into your project timeline. So even before you have broken ground. Absolutely. After that comes the key role of the PMCM in really ensuring that the cash flow for the project and also management of the contractors, the primary contractors involved. Now, there are some projects where you might appoint one large contractor who has got all the sub elements under that person's umbrella, which is very easy to manage. It might be slightly expensive, but there are some other hospitals who prefer to decentralize and have multiple contractors, where the PMCM, the project management and the construction management team, will control various contractors in a cohesive, coordinated manner. The challenge when you do this thing is, another important element is because you already have planned as part of your functional planning of the hospital, and your specialty mix, your biomedical matrix is already there. Compared to normal civil constructions, I think the one fundamental complexity of a hospital design is the element of the biomedical element to really embed these sophisticated equipment, and also from an infection control point of view, the infection control protocols. Now, there are many parts of the world, especially closer to the equator, tropical countries, where hospital planners unfortunately do not estimate, for example, simple thing about the level of your groundwater table. When you plan your foundation, is your foundation based on pile, or is it some other design? Now, groundwater seepage is a big problem for many hospitals, because that foresight was not there when you actually build the foundation of the hospital, or you're actually closer to a water body. Then the challenge of floods and flood mitigation, where exactly is your high-end capital intensive biomedical equipment is placed, because if you are prone for floods, you may not be able to place it on the ground floor. You'll have to take it on a floor certainly higher. 6 months before you're opening up for your first patient, you should have your consultants on board. Again, hospitals would say that, well, that's very expensive. How can you have most of the consultants on board? So that you can actually have a facing strategy. Like you can have a core team, let's say one surgeon, one anesthetist, maybe one intensivist, one core team you could have 6 months before. And then you can have a phased recruitment based on that doctor's current situation of engagement, maybe with some other hospital group. You could have that plan, so that the intensity of recruitment is usually 60 days before the opening of the hospital. Now, you should not cut it lesser than that. The reason is it's a new team. It's a new clinical team, new leadership structure.
So I think moving on, I think another important point that I want to really pick your brain is, doctors are like the nerve center of the hospitals, and are extremely important stakeholders. And they also constitute one of the largest operational costs of running a hospital. From your experience, I think what models work well in terms of doctor association with the hospital, and what probably did not work well. So here, I think to be more specific, I'm talking about a fixed salary model, or is it a fee-for-service model, or a hybrid? Also, which works well, and for what type of a hospital? When I say what type of hospital, is a trust hospital.
Good question, Raghav. So this is basically the centerpiece of any hospital administrators should be part and parcel of any hospital administrative strategies. To have a fee-for-service model, definitely, but in the context that I only gave privileges to consultants who are willing to be exclusive to me in the private landscape. But I said you can work for the public sector, for university hospitals. Most of them were attached to Cairo University. I said that's really good, because I really expect my doctors to have the academic element involved, because I really believe you are a good doctor if you're a good teacher. That's really my core belief. So this combination of them giving time for the public system through Cairo University, and then in the private sector only for my hospital, it really worked out. So what is the carrot which I said I will give is that I said I'm going to invest more on marketing. Number one. Number two was that earlier, if you look at the cash credit balance, the doctors used to suffer that for the credit cases, the receivables were for an incredibly long period of time. It is much beyond 6 months to 8 months. And the doctor's professional fee was stuck, and it used to be paid only when the hospital used to collect the money. So what I said was that I would like to pay for you your doctor's fee for those credit patients on a monthly basis, with a deduction of 20% for my risk of collection in the future. Now, that is my headache. I will go and figure out the efficiencies and how to collect. But for you, my doctor, because you're loyal to the hospital, I'm going to pay you your professional fee at the rate of 80%. And all the doctors agreed, because that was something which was never done before. So you have to create elements of stickiness. How do you improve stickiness? And you have to actually think from the doctor's point of view, like, why should a doctor struggle? Every doctor wants to provide good care for the patient. They want to have the sense of security that the hospital will look after them, will give them a steady base of patients, will invest in medical equipment, improve capacity, and improve the reputation of the hospital. And there's a sense of pride associated with a good brand. So
Right.
that was the journey which we did in Cairo. I think that intense focus on having that. From a contractual point of view, you have a 10-year contract of, let's say, it could be 12 months to 24 months of where the hospital gives a guaranteed amount of money to the doctor, so that it's a new hospital, the teams have to settle down. You're investing in marketing. All you expect from the doctors to give time to build a clinical profile to the the referring base. So that's all the doctors usually do in the weekends and others for the CME programs and webinars and things like that. And the hospital gives them a guaranteed tenure, which is stable. So it gives them stability also. Now, once the ramp up took place and the hospital volumes increased, we also started giving them a revenue share based on the professional fee element. Now, one of the key dictums in the engagement with doctors is that there shall be no incentives paid from diagnostic referrals or from anything else. So the idea was, and I do recollect that in the opening vision document, I'm the one who's going to address all the whole teams, including the doctors. And I used to tell them that, yes, this hospital has got the best possible medical equipment in the world. But if you make a wrong referral, just for the sake of, which is not warranted, I would be the first guy to come and ask you the question that why did you refer for a diagnostic procedure which is not required for the patient? So that's what I meant of being very strict and disciplined and following evidence-based pathways. And therefore, the incentive model of the doctor had nothing to do with all these things, purely his professional fee, which is in any way predefined in the hospital. So basically, that's the scenario there. In the Philippines, of course, it's early days, but broadly, the practice here is mostly like what you see in Western India, especially in Mumbai, or like I told you in Egypt, that doctors are used, they're all independent practitioners on a fee-for-service model. No hospital gives them a kind of a retainer, and usually they go to multiple hospitals. That's the current model, what you see here. I do have based on my experiences in other markets, I do hope to bring a paradigm shift, because I empathize quite a bit with doctors. I am a doctor myself, so I understand the challenges of being a doctor in these kind of markets. So I want to give them a sense of security, and I'm also asking the hospitals to really help the doctors.